Welcome to Talking Meds on the PrescQIPP podcast, engaging conversations about medicines-related dilemmas. I'm your host, Jonathan Underhill. Hello everyone, welcome to Talking Meds. I'm your host, Jonathan Underhill, and today I'm joined by Dr. Lucy Pollock. This is the third in a series of podcasts on sensible prescribing in older people with Jonathan and Lucy. Today we're going to be talking about heart failure in its most general sense, but we want to talk about the different types of heart failure as well. Now, Lucy, you can correct me if I'm wrong here, but heart failure, I get a sense that that's been transformed by the pharmacological, the medicines that are now available that weren't available 20 or 30 years ago when I first started training as a pharmacist. But there's still, I think, a perception of maybe some overprescribing of certain medicines for heart failure, certainly in our precious older people. And I know that's something that you feel very, very passionate about, isn't it?
I think that's a really good place to start, Jonathan, because there's a combination of both overprescribing and underprescribing. So there are patients who aren't getting the right medicine who would benefit, and there are patients who are maybe getting the wrong medicines and are running into trouble. And this is a really controversial issue. It's also really important. It's been a real pleasure watching the developments in heart failure treatment over the last 20 or 30 years. As you say, basically our careers have been spent moving from treatment being a loop diuretic, that's it, through to these amazing new medications that make a huge difference to quality of life, to the risk of hospital admission for the right patients. There's also a real deepening of understanding about what the pathology is in heart failure and the fact that not all heart failure is the same thing. So if it's all right, I thought maybe we would start with a little bit of a discussion about the fact, why does it matter? Isn't heart failure all one thing? Why does it matter what sort of heart failure somebody's got?
That sounds like a great place to start.
Great. That's good, because we need to set aside a couple of types of heart failure that people will be very familiar with. So all of you will meet patients who've got bad valve disease. That's becoming less common as we get rid of the infectious diseases that used to cause things like mitral stenosis and so on. But we have got a lot of older people who've got type aortic stenosis. And those patients are a different category, and they do not come into the trials of heart failure treatment. They're excluded from those trials. So if you've got somebody with severe aortic stenosis, set them on one side. They need a different approach to their medication, guided by your cardiology colleagues. Similarly, we are all very familiar with the patients who've got terrible lung disease, and their heart failure is more right-sided heart failure, so they get really puffy legs. They are breathless, but it's not because they've got fluid on their lungs, it's because they've got terrible lungs with COPD, and they have a different kind of heart failure, right-sided heart failure, or cor pulmonale, which is much more mechanical heart failure, and again needs a different kind of treatment, which is mostly based on diuretics and getting your legs up in the air. So those are the two to set aside, and then we've got our left ventricle. And I want to simplify this if I can, and just give you an image. If you put your hand up in the air as if you've got a great big light bulb in it and you're going to be screwing it into the ceiling, and you look at your hand, that is a left ventricle. And what that left ventricle can do is give a good squeeze. So squeeze it and see what happens. What should happen is that in health, more than 50% of the blood in that left ventricle should come out and whiz around your body. And if you've had a heart attack or something that's damaged your heart muscle and it doesn't squeeze properly, you can see that you make a little tiny squeeze and less than 50% of the blood in there comes out. In the original heart failure trials, the heart failure with reduced ejection fraction, you find it less than 40%. And for some people, it might even be less than 20% of the blood in that heart comes out with each squeeze. So you can see those people are going to run into trouble. But there's another kind of person with heart failure, and they've got just the same symptoms. They're breathless and tired, and you examine them, they look the same. They've got a raised JVP, and they might have a gallop rhythm, and you listen to their lungs, and you've got all these little tiny fine crackles at the bottom of their lungs, or they've got a pleural effusion, they've got edema, and they look the same. But when you do their echo, it comes back and says normal ejection fraction. and you think, oh, hang on, what's going on there? It says it's normal. It isn't a normal heart. The problem is it doesn't relax. So that muscle doesn't relax to allow the heart to fill, which means there's not enough blood in there in the first place. It doesn't matter what percentage of it comes out, it's not enough because there wasn't any in there. And that is heart failure with preserved ejection fraction. And geriatricians in particular are interested in that condition because it is a defining condition of aging. So people with preserved ejection fraction tend to be older. It's more common in women. It's common in people with obesity and diabetes and hypertension. So if you've got an older lady who's diabetic, hypertensive, and a bit overweight, you can bet your bottom dollar that she's almost certainly going to have
I think that's a really, really good revision for me, actually. That's been really helpful. I remember when I first learned about heart failure, I was told it was what was called a duck diagnosis. So if it's got a beak, it waddles and it quacks, it's a duck. With heart failure, it was you've got symptoms, you do an echo, there's a reduced ejection fraction, and it responds to treatment, then it's heart failure. That's not the case now because there is heart failure now that's been defined as being preserved left ventricular heart failure. So yeah,
exactly.
Really helpful.
So there's lots of ducks. We're talking mallard ducks, muscovy ducks, little brown ducks, white ducks, loads of different ducks, and we're going to have to get our ducks in a row. So
we need to understand, has my patient got heart failure with a reduced ejection fraction, in which case you're looking at these incredible new treatments, what we're going to call the 4 pillars, and we'll talk about those in another session. Or you're going to talk about your patient with HFpEF, with reduced ejection with preserved ejection fraction, who is tired and breathless and getting plenty of symptoms.
And we'll come on to reduced rejection fraction in another podcast, won't we? Yes, because they are very different, and we'll talk about the 5 pillars of treatment.
We're not going to ignore it. It's a really important subject.
Indeed.
But let's start with HFpEF in a way because it's simpler as well to think about, but it's also really important because it is most older people are going to have HFpEF over the age of 80, over the age of 90. It's important. It causes problems with quality of life. It reduces your life expectancy. It's a really important condition. And we also know that our treatment options are more limited. And it's not because they haven't done the trials of these other medications. They have been done in patients with HFpEF, but the results are nothing like as compelling as they are in condition with the reduced ejection fraction. So how do we treat people with HFpEF, with preserved ejection fraction? The first thing is we give them some symptomatic treatment. We give them diuretics, loop diuretics to offload, and those work. We've all seen someone who is really in trouble with heart failure with a freezing cold nose, very breathless, edematous, crackling, overloaded, frightened, and we know that we give them a decent dose of furosemide, and my goodness me, they feel better. So that's fine. We know that that's a good treatment. Go, Jonathan.
So what sort of dose would you go up to for that then? About 80 milligrams, is it, Lucy?
It will entirely depend on the patient. If you're somebody who is completely diuretic naive, who's never taken a loop diuretic in their life and their symptoms aren't severe, you might start just 20 or 40 milligrams.
Okay.
But you need to be prepared to escalate because you may need quite a lot more than that, and we end up with people who may be taking 80 twice a day or transferred onto bumetanide. We can talk about that later. Is it worth it? I mean, it makes no difference. But you may need big doses of furosemide to offload the fluid for that person.
And for preserved ejection fraction, there's no evidence that ACE inhibitors, beta blockers, and the others work, but there is evidence, and indeed it's recommended, that you might want to try dapagliflozin or empagliflozin. They're the two kind of medicines that we're interested in here, aren't they?
They're the magic medicines, and they are increasingly recognised as having a role in lots of conditions, clearly in diabetes, but also now in people who don't have diabetes but do have heart failure. So we might just do a quick think about the pharmacology and why that works, because it's interesting. So these are called the SGLT2 inhibitors, and what they're doing is they're inhibiting a sodium glucose mechanism in the kidneys. And I always say you can remember how they work because they're called gliflozins, but actually what happens is the glucose flows out.
Thank you.
They mean that your kidneys start losing sugar. Okay, so that instead of the sugar being reabsorbed in the tubules, it's left alone in the tubules and it flows out. And we know that glucose flowing out is a very powerful osmotic effect, and it drags water with it. So basically they're acting like a diuretic. You know, you remember that when people present with diabetes, they're very thirsty and they pee all the time. Well, that's all that sugar in their urine making them pee all the time. And the gliflozins are basically doing the same thing. They're pushing sugar into your urine or letting sugar flow out in your urine, and the water follows it. And that will give you a clue as to what the downside is, because they're an effective diuretic, and they may also have a separate effect that's less well understood on the actual cardiac muscle itself, but their primary effect is in the kidney. And you think, okay, sugary urine and lots of urine, what are the problems going to be? Well, they are dehydration with postural hypotension, and they are an increased risk of urinary tract infection because you're peeing sugary urine. Those are the important ones, and for most people they're not a problem. These are very good drugs that actually are really well tolerated, and they do make a difference. So there's some good composite outcomes in terms of death and reduction in readmissions with heart failure and cardiovascular death for the gliflozins, but there is a downside.
Yeah, that's really, really helpful, Lucy. So what about things like sick day rules and things like that? So if someone's got nausea and vomiting or is dehydrated, what would you do with these medicines then?
Yeah, the sensible advice, which is to watch out for volume depletion. So patients do need a warning about that. And we know that if they come into hospital unwell with a serious illness, we stop the gliflozin for a while. And I think the same would apply at home. If you've got a really nasty vomiting virus and you're at risk of getting dehydrated for a few days, just pause that gliflozin for a couple of days until you feel better would be sensible patient advice. For patients with diabetes, they're recommended to watch out for signs of diabetic ketoacidosis, but most of these patients where we're using it in heart failure, they don't have diabetes. That's not a risk for them, but the volume depletion is. And then we can talk about the urinary tract infection, because this is a really tricky one, because UTIs are not all the same. So there are lots of people out there who get mild UTIs and they're not that bothered by them. They know their symptoms, they get a bit of dysuria, and they know they're going to get a UTI, and they can treat it very quickly, and it doesn't cause any trouble. And for somebody like that, maybe a slightly increased risk with your gliflozin isn't really a problem. They'll cope with it. But think about my patient Marjorie last week. So she's in her early 80s. She's a really independent lady, looks after herself. She's got some HFpEF. She's been started quite rightly on some dapagliflozin, which is great, together with her furosemide, and she has come in with a devastating urinary tract infection with delirium, and she is horribly confused. The first few days of her hospital admission were miserable for her. She didn't know where she was. She was very distressed. She was at high risk of falls because she was fluctuating between hypoactive delirium and hyperactive delirium. And it's taken her, she's still not right yet. And what we know is that delirium is a life-changing illness for many people. It is not a benign condition. It's not, oh, let's treat the UTI and you'll be better in a couple of days. We know a third of people with delirium never come back to where they were before. We know that having an episode of delirium predicts dementia. So it's associated with an increased risk of dementia. So she really does not want to have another UTI. If I was Marjorie, I would not ever want to have another UTI. I would do everything in my power to avoid having something like that again. And that may well include stopping the gliflozin. It is not worth it for her to be on something that is increasing her risk of something like that. Yes.
So I think that's a really, really good point. So from the trials, from the Emperor trial, which is where most of the data comes from, I think the number needed to harm for urinary tract infections was 100. Mm-hmm. So for every 100 people that you treat with empagliflozin or dapagliflozin, one of them will have a urinary tract infection. But of course, the people in the trial, in the Emperor trial, were not like Marjorie, were they? They weren't. No. They didn't have comorbidities. They potentially weren't as old as Marjorie. So I think you probably have a higher index of suspicion if someone presents with confusion or delirium when they're on empagliflozin or dapagliflozin. It's probably going to be a higher prevalence than 1 in 100, isn't it, for this? So again, it's just something to watch out for, isn't it, Lucy?
Yes, absolutely. And this is where we come to some of the controversy. because you're absolutely right, Jonathan. The people in the trials are not the same as the people that you're seeing in primary care, that geriatricians are seeing, that maybe clinical, that pharmacists are seeing, prescribing pharmacists. Now, there has been some good work trying to look at frailty within those trials, but what we have to acknowledge is that on the whole, even the patients with frailty, so-called frailty, again, not all frailty is the same. You don't go not frail and frail. You are on a sliding scale of frailty. So the people who are defined as frail in many of those trials weren't actually what you or I might recognise as frail. So I don't know if you're familiar with, I'm sure you are, with the Rockwood Clinical Frailty Scale, but when one looks closely at the frailty index of patients in the frailty subgroup sets within those trials, you realise that those are people with a Rockwood that would correlate to a clinical frailty scale of about 5, living with mild or very mild frailty, whereas you or I might be picturing somebody who actually is living with considerably more 6 or 7 levels of frailty. And they were, on the whole, not represented in the trials. What can we do about that? We absolutely must have good trials in people with significant frailty, and that's a real call to arms for the researchers.
It certainly is. So just to recap then, so in terms of treatment of people with preserved ejection fraction heart failure, then diuretics are the mainstays, treat the symptoms, and then consider putting consider the benefits and risks of putting somebody on dapagliflozin or empagliflozin. And would you have that conversation with how would you explain the benefits and risks to people? We talked last time, didn't we, about GP evidence? Julian Treadwell's really helpful resource that gives you those numbers for some of these common interventions. So gpevidence.org is how you find it, and if you click on preserved heart failure, there is a really good series of icon arrays or Kate's plots, smiley face charts, where there's 100 people, and if you give, just looking at this one here, which is for reduced risk of hospitalization for heart failure, so that's a patient-oriented outcome. People are bothered if they get admitted to hospital with heart failure. It's something that they're concerned about. So people who aren't treated with empagliflozin or dapagliflozin, you have about 12 people admitted to hospital over 2 years with heart failure. If you put all 100 on dapagliflozin or empagliflozin, that reduces to about 9 people. So there's 3 people who are safe from going to hospital over 2 years. But this isn't a cure-all. Not all 100 are prevented from being hospitalized. It just reduces their risk by well, as I say, 3 out of 100. And that's the sort of thing that you need to explain to people when they're making this choice, this investment, as to whether they want to take this medicine or not. Because we've talked about the downside of that. For every 100 people, maybe more than that actually, you'll get one who has a urinary tract infection, maybe 2, maybe 3 people like Marjorie who get a urinary tract infection. So there's always a trade-off here, isn't there, Lucy?
It's really subtle, and the other subtlety is that people with heart failure with preserved ejection fraction often have other things the matter with them, and actually they're more likely to come into hospital because of other causes rather than a readmission with heart failure. Lots of other things bring them into hospital. Having said that, there is some evidence that all-cause hospitalisation is improved. So what I'd say is, if a patient can tolerate that and would like to take it, give it a go. I think they're very good drugs on the whole, but go in with your eyes wide open. If the patient doesn't want to take it, that's fine. It's not the be-all and end-all, but also be prepared to stop it. And probably, if somebody's had a bad time on it, like my lovely Marjorie with her horrendous, delirious UTI, I don't want her to go through that again. Or if somebody is being admitted with hypotension and dehydration, I wouldn't try and keep pushing those medicines because that patient is declaring they can't tolerate it.
And for Marjorie then, so she's admitted in hospital, she has her urinary tract infection treated, and then on discharge, would you restart the empagliflozin or dapagliflozin or what? I know it depends, but
for me, no. I would say I would be having a conversation with her about what drove. You've got to check it was a UTI, it wasn't something else. You get your diagnosis right. But say she's had E. coli, proven urinary tract infection with a spanking delirium on top of it. I would not. I would do everything I can to reduce her risk of having another one, because to be honest, her life is going to be ruined by episodes of delirium.
Absolutely. And
So
actually, you're probably unlikely to clear the E. coli as well, aren't you? So anything that's going to increase that risk of that coming back, you want to try and avoid. So hydration would be really important to emphasise that.
Exactly. So there I'd be talking to her about keeping on top of things with her diuretics, and then obviously treating all the other things, reducing her risk of getting a urine infection with, for example, things that are really simple and overlooked. Make sure that you're drinking a reasonable amount, decent personal hygiene, which may involve having proper care put in place. And another thing we never talk about is vaginal estrogens. And, it's just a taboo subject, and we don't get to grips with it nearly often enough. They've got a really good NNT in older ladies with recurrent UTIs. Some topical estrogen, doesn't have to be fiddly pessaries, just topical cream, get it in the right place.
Absolutely, and that's in the NICE guideline on recurrent urinary tract infections, Lucy, is one of the options to explore vaginal estrogen. So absolutely. Lucy, thanks very much. Again, really, really helpful, insightful conversation about tricky therapeutic dilemmas. Medicine is not easy, is it? It's a tricky thing. Computers can't do this. It needs human beings to interpret this and apply it to individuals. And this is what this is all about. And talking to people like you who do this every day is really, really helpful, I think.
Thank you. I think medicine is difficult, and that's why we do it.
Exactly. Cheers, Lucy. Thanks for listening, guys. I'll be back in 2 weeks' time to talk about the update to the NICE menopause guideline and why this is really important. I chat to Hayley Berry, a pharmacist who was part of the guideline development group for that. And then in 4 weeks' time, we're back for a Christmas special with Jonathan and Lucy. So ho ho ho, get your Christmas shopping done. As we say in my family, Santa's coming, champion.